Good afternoon, and welcome to our value-based health cast. My name is David Hanna. I'm a doctor and I work in Cardiff.
I'm Nick Wilkinson. I'm a paediatrician, also based in Cardiff.
And this is our monthly session on value-based healthcare, brought to you in conjunction with the Wales Value and Health Centre. And it's an opportunity for us to meet interesting people, learn more about value-based healthcare in Wales and what's happening across the country and the UK. And today you might notice that our settings are a little bit different.
Yeah, we're missing the yellow sofa and Hilda the pot plant and the cups of coffee that we get.
Yeah, but we've got rapid broadband and high quality internet. What we hope is an interesting session for the next hour, and the opportunity for you as participants and people who are joining us from across Wales to ask any questions you like about value-based healthcare in Wales, and particularly about the session and the topic we're going to be talking about today.
Yep. So it gives us a great pleasure just to invite Julia Platts, who is a consultant diabetologist based at Cardiff and Vale, and she is the national clinical lead for diabetes for Wales. So really pleased for Julia to join us.
Thank you very much. Thank you.
Are you there, Julia?
Can you hear me?
Definitely is. I can see something happening.
Yes. Can you hear me? Hello.
Okay. Can't quite hear Julia yet.
Hi. Can you hear me now?
Okay. Oh, there we go. Hi, Julia.
Hi there. Is that okay?
That was our rapid broadband, but loudspeaker not turned on, so apologies for that. Welcome.
Okay. Thank you. Are you happy for me to start?
That'd be fantastic, Julia.
Brilliant.
But before you do, maybe Julia, we've given you a very brief introduction, but maybe you'd like to tell us a little bit about who you are, what you do, and what your role is. And you can pop your camera on if you'd like to do that.
It is on, actually.
Right. Well, hopefully that'll flick on in a second.
Hopefully that'll come through. It is turned on. Yes, I'm Julia Platts. I'm a consultant in diabetes in Cardiff. I started as a consultant actually in diabetes in North Wales. I moved to Cardiff, and for the last, I don't know, about 7-8 years, I've been national clinical lead for diabetes in Wales. So this is a very interesting question for me. And for the last couple of years, I've also been working together with the Value in Healthcare team and also the Finance Delivery Unit. So I'm delighted to come today. So I'm going to kick off by saying, really, I'm pleased to be asked to explore the topic of value versus quality in healthcare, because I think I'm going to do it through the lens of diabetes. And I think it's a really appropriate subject to use to examine this, because diabetes is it's a very common condition, about 8% of the population, and it's a cradle to grave condition as well. So throughout the life, and it touches all aspects of life. We have the medical side of things, you know, where we work to try and stop the acute complications like the diabetic ketoacidosis and the chronic complications like the blindness, the amputation, the kidney failure. But the social aspects are such a crucial part of diabetes, the living with diabetes on a daily basis, the people who live with diabetes having to make decisions constantly about what they can do, what they can eat, what exercise they can do, can they drive, what medication they can take, can they give a lecture, and the way in which it touches all aspects of life, such as education, employment, travel, festivals, going out, going to the gym, pregnancy. So it's a really vital subject matter. we're always told it costs about 10% of the health budget. Those are very crude figures. And we're always told that 80% of that is spent on treating complications. Again, very crude figures. And over the last couple of decades, really, we've had improvement plans to improve diabetes care. In the noughties, we had the National Service Framework, and in the last 10 years, we've had the Diabetes Delivery Plan. And I think there have been some successes in diabetes, such as falling cardiovascular deaths. But I think lots of issues are still not being met. If you talk to people with diabetes, for example, people with diabetes will tell us that the mental burden of having diabetes is such a large one, and we really just don't get to address that at all. So I shall start with my slides. I think Brooke is going to share them for me. Thank you, Brooke. So my question that I've been asked this afternoon is, in healthcare, is value the same as quality? Next slide, please. So the definitions that we can see if we look into this is that value-based healthcare is the equitable, sustainable and transparent use of available resources to get better health outcomes and experiences for every person. So the focus is on outcomes rather than volume of work, whereas quality is really just one aspect of value. And quality is thought of as the clinical effectiveness, safety and good experience. So, for example, I could do a clinic, I could see 3 or 4 people and just give them amazing quality care, spending lots of time with them, but neglecting anybody else who needed care. Or similarly, I could see somebody in clinic, I could start all the latest medications because that's what I'm told will give a person a quality service, and the person is feeling really not very happy because what they really wanted was deprescribing. So as I said, quality is only one component of value. Next slide, please. So diabetes services traditionally have used a quality model. If you look at all our audit data, we're looking at the proportion of people who've had various care processes, such as HbA1cs, blood pressure, foot checks. And we're also looking at the proportion of people that are under various thresholds, such as HbA1c thresholds, cholesterol, blood pressure thresholds. And the reason for that is that there is evidence that if we target these various parameters, we will reduce complications, although I have to say that we apply that blanket across our populations. And if you look at the evidence is really that good early control is what is important rather than control of these factors later on. Next slide, please. So more recently, we've started to try and look at the outcomes that actually matter to people with diabetes. What people with diabetes are terrified of is vision loss, blindness, loss of a limb, loss of a baby. And more recently, we've also seen what people want. For example, there's something called a Freestyle Libre, which is a new technology for measuring blood glucose, which is a little sort of patch that sits in a person's arm that they just scan, and it stays there for 2 weeks, and they can tell what their blood sugar is. And surprisingly, people much prefer this to stabbing their fingers with lancets and drawing blood several times a day. And so this has given us an opportunity to say, well, we have cost effectiveness. This is the cost effectiveness model for looking at this particular technology. And then we have the clinical effectiveness model for looking at this technology. You know, how much does this improve a person's HbA1c? How much does this reduce hospital admission? But one thing that we've been very poor, I think, traditionally at taking into account is what the values of our patient population, our users want. And I'm quite convinced that for our users, this technology is far more important than perhaps me starting the latest, most expensive medication. Next slide, please. So back to our complications of amputation, sight loss, baby loss. We've been working together with the value-based health team and the wonderful finance delivery unit to develop an atlas of variation, the DIVA, the Diabetes Insights and Variation Atlas. And what we've been doing with this is starting right at the end stage complication. We've been starting at the amputation, and we've been working backwards to try and identify those factors that would make a difference, that we can do differently, that we can actually prevent amputation, whereas previously we've always come in at the start of the pathway, and we've done large volumes of foot checks. But what we are finding is that this isn't necessarily reducing amputation. So we're trying to look at things from different angles, look at different aspects, different interventions to find out what's really important. Next slide, please. So what we're trying to do with DIVA is take our practice and put it into data, and then look at that data and gain what knowledge there is to gain from the data, and then put that knowledge into practice and try to repeat that cycle, rather than continuing to do what we've always done, what NICE tells us we should do, and expecting different results. Next slide, please. So I'm going to share with you two dilemmas, because I'd be interested to know what the audience feel on these. As I've already mentioned, diabetes consumes 10% of the health budget, huge amount, 80% on complications. So the first thing to note is that type 2 diabetes can be prevented. At least a proportion of it can. If we recognise those people at high risk, put in specific intervention, we can stop it happening in the first place. The second thing to note is that around half of people with type 2 diabetes could enter remission. There's a specific program that enables people to do that. If you're within 6 years of diagnosis, that's half of the people within 6 years of diagnosis could be put into remission and no longer have type 2 diabetes. And as I've said before, good early effective control, so I'm talking early months to early years, reduces complications 20 to 30 years later. And that's something we can't catch up with if we start good control 5-10 years down the line. It's too late. It's too late. There's a legacy effect. We've got to do it early. So what I'm saying is that our health budget to get value really needs to be redirected to that early prevention, that early remission, and that early good effective control. But we can't do this because we're currently spending all our resources on complication management. And when I say that we need to do these things, there's no money to do them. So my first question is, how do we break this cycle? How do we break this cycle and enable resources to be put into where we can stop diabetes and reverse diabetes rather than treat the complications? Can we afford not to do this? Is my next question. Next slide, please. My next dilemma involves type 1 diabetes. There are new devices out called hybrid closed loops. They've been out for a couple of years. They're insulin pumps, which have been recognised to improve diabetes control, clinical outcomes and quality of life outcomes. And there is a NICE technology appraisal, which is poised to be published, which is going to recommend one of these hybrid closed loops to anybody who's got type 1 diabetes with an HbA1c of over 8%. Now, we already have pump services. They're an area where there's a lot of inequality. People who have the highest levels of deprivation and different ethnic groups seem to struggle to navigate to getting onto pumps as it is. We've got about 16,500 people with type 1 diabetes in Wales. On the latest audit data, about 3,900 have got HbA1cs of over 9%, 2,000 over 10%, 5,000 unknown, and they're probably high because these are the disengaged people, let alone going for the 8%. And we have limited staff resources. If I speak to any centre in the country, they are so hard pressed to just carry on what they're already doing. And this is where my dilemma comes. Those people who've got lower end HbA1cs are much easier and much safer to onboard a pump. Next slide, please. We know that these people are less likely to go into diabetic ketoacidosis. Those people who've got higher HbA1cs are far more challenging to put onto a pump. It's far more risky in terms of the fact that they may go into diabetic ketoacidosis. We need a lot more staff resources. Added to this, that we know our more deprived groups often have a lower health literacy and often a lower literacy in general, and often have access to less IT equipment, such as phones, smartphones that we need to help this equipment. But what we also know is the higher the HbA1c when starting a pump, the far greater the benefit. So my question really is, where do we start? The lower HbA1c people who are likely to be successful won't require that much staff resource, or the higher HbA1c people who are greater risk will need a lot more staff resource, but there's a much greater potential gain. So I'm going to hand over to you guys with my dilemma to see if anybody can help me with my dilemmas.
What a brilliant dilemma. Well, not for the patients, but I mean, you've really encapsulated sort of what value is about there, because you're thinking about your population in different ways. I was fascinated how you took your outcome and wanted to work backwards from that, and I think that's a brilliant conception. And then obviously, you know, what you're talking about is distributive justice in a way within healthcare, thinking about, well, who most deserves the support that we need for the greatest gains. So it's beyond a sort of utilitarian view. So I'm fascinated by that.
Yeah, likewise. It's always one of the really interesting things I find about doing the HealthCast is that I learn all about parts of healthcare I knew nothing about before. And children with diabetes, who tend to be the patient with diabetes that I see, generally come to the emergency department when they're in crisis, acute crisis. But really the burden, the healthcare burden for people with diabetes is much more weighted, I think, towards the long-term complications. And for me, Julia, the really interesting thing, or one of the interesting things about what you've said, is so many of the common threads that link what you're talking about to previous people we've had on the HealthCast. So your use of data to knowledge and trying to find the data that's going to help, the prevention, and probably a bit around the patient-centered care, which we talked about in one of the previous episodes as well. What I wanted to do before we continue is just to give it a quick recap for those of us those of you who might have just joined. So welcome to the Value-Based HealthCast. This is our monthly session on value and health in Wales, brought to you by Nick Wilkinson and myself in conjunction with the Wales Value and Health Centre. And today we've got Dr. Julia Platts, who's the National Clinical Lead for Diabetes in Wales, and who's a consultant diabetologist and clinician working in Cardiff and Vale. So Julia, I'm really interested to know about how you marry your local role as a diabetologist and the challenges you have with delivering care to your local population with your national clinical lead role. As you said, you've been in it for, is it 6 or 7 years, and how those competing priorities align.
And to be honest with you, they don't compete very much, which is quite nice. You know, it's quite nice because it just means that I'm immersed in diabetes all week. And, you know, my local colleagues, my national colleagues, Wales is such a great place to work because you always know everybody. And that's really lovely. So it hasn't been much of a stretch for me. I think when I started it, I was part-time, so it was fairly easy to add in additional sessions. The problem is over the years the sessions grow, and it does get more time consuming. But I think it hasn't seemed challenging to marry the two things up. I also try quite hard not to be Cardiff-centric because I work in Cardiff, but I'm very fortunate to know lots of people all over the country, which has been fabulous. And it was also a very happy day for me, I should say, when I met the value-based healthcare team and also Claire Green from the finance delivery unit. Those guys have been fabulous.
So just thanks, Julia. It's just coming to taking that theme and thinking about your second dilemma, which was between investing in those who have already invested themselves into the service and those who are struggling, if I was just to encapsulate it this way. One of the things might be that your colleagues and staff and the team do they conceive of this sort of dilemma too? And do they conceive of this at a national level, a population level, or just within those who come into the clinic? How does it sit with your colleagues?
I think my colleagues often think about it in their local population rather than the wider population. And I think the pressures people feel, as I said, are the staff resources, because it's much easier to see people as a group and use group consultation and that sort of thing. And quite often we have people who've got individual needs, and their needs are greater, and obviously it takes a lot more staff resource. I think what we have across Wales is a lot of varying practice when it comes to technology. We have centres that are quite to the forefront of technology, and we have other areas in Wales that struggle with technology for various reasons, and some of those reasons are local barriers, and some of those reasons are staff, staff appointing staff, retaining staff, seem to be big barriers. So I think colleagues largely, to be fair, look at their own populations rather than Wales as a whole. I'm faced with trying to find a plan in Wales. That there is a plan in England being devised, but because of the remuneration in England, there's going to be a very different plan there, where super centres are going to be paid to do it for the whole of England. And I think in Wales we have to work out. We have to work out, first of all, what our priorities are. What people would be happiest doing, whether it would be volume of work or whether it would be what would be more attractive for me, which would be going for the people with greatest clinical need, accepting that those people will require more staff resources, and will ultimately be less comfortable for staff to use this technology with.
So that's really interesting. And so I understand the difficulty that you're facing is staff retention, and therefore you're losing experience and knowledge of the population, and then feeling comfortable where there is different levels of complexity. Am I right in thinking that?
Yes, absolutely. And also I think we've got a situation where this has been regarded in the past as quite a niche area, and now we're talking about it becoming very mainstream. So perhaps within centres only a small proportion of staff would have managed this particular situation, and now suddenly we're saying, right, this is going to be the bread and butter treatment for this condition. So there is a staff training element that we have to look at as well.
Because if you're losing the key staff who have the knowledge, because what I'm finding in other areas is those staff bring with them the new solutions, and I wonder if that's happening within, I'm sure it is within diabetes, but to what extent?
Yes, yeah, I think it is happening. I think we've got a big issue with succession planning, across the board in diabetes. You know, we have a lot of people will retire without an appropriate replacement person being trained into that role. And that's even at a basic level, let alone when you get into the speciality level. So there is a big issue, I think, across Wales with succession planning. And, you know, we need to be better at it, so that we know years before people are going to retire, when they're going to retire, but we don't specifically train people up into those roles so that they can replace them.
Because I think what you're identifying, Julia, is how complex this is, and you presented a sort of a binary decision making there in the dilemma, but yet you're adding now all the levels of complexity and all the areas that you have to think to achieve value. Is that a fair reflection?
Yeah, yes, I think it is. I think it is. And to be honest with you, the situation won't even be binary. You know, it'll be, you know, people will have multiple issues at multiple levels. I'm just sort of putting it into the level of, yeah, these patients are fairly straightforward. These patients are a lot more complicated, but I've got so much more to gain than the easier, so to speak, patients.
Julia, I was really interested when you were mentioning some of the measurable things that traditionally you've measured in diabetes. So things like HbA1c, cholesterol, blood pressure, and you said something that we're really familiar with as clinicians, is that traditionally we've measured things which we assume that will, if we control them or improve them, will lead to better outcomes. But a more value-based healthcare approach is to ask patients what's important to them, and you talked about the freestyle devices. I'm just interested to know how you learned more about what was important to your patients, to people with diabetes, as part of the work.
We're pretty fortunate in diabetes in that we've got an all Wales patient reference group. That's a kind of a formal structure that takes opinion, and I know it's only a small population of the people living with diabetes, but you know, they take opinions on what is important to people with diabetes, and that's why I say we are repeatedly told that the mental health aspects of diabetes are not being addressed appropriately, and they're not. You know, we all know how mental health services are groaning, and this is something that I think is probably only relatively recently being appropriately acknowledged. You know, that this is a large aspect of chronic disease management, and it's one that we haven't paid much heed to in the past, this psychological support. And, you know, there's a lot of work being done now into how we can address that. You know, we've got a huge lack of psychologists. Even if we had money for psychologists, we couldn't appoint them because there aren't such experts out there waiting to be employed. So we're looking at all kinds of aspects whereby we can improve psychological support. But I think a lot of things like, for example, I mentioned the Freestyle Libra. This is just through meeting a wealth of people. You can meet a wealth of people in your clinics or at events, and they will tell you how important it is to them. They will tell you what it's meant to them. And you don't think about it. You don't think about, gosh, imagine every time you go to eat something, you've got to associate that with the pain of stabbing your finger, or, you know, and lots of people don't do it because it's painful, and you know they avoid activities. People with diabetes often avoid exercise because, you know, they'll have to start stabbing their fingers and, you know, having all sorts of problems with it. And I think that's why I was saying at the start that diabetes is such an interesting thing to look at value through the lens of, because living with diabetes, I think, is an entirely different thing to being a healthcare professional trying to do medical management of diabetes. You know, we can say, oh, look, Mr. Jones, you're fine, you know, oh, you're doing really well, off you go, it's looking good, you know, your cholesterol's fine and this sort of thing. But what we don't live is the daily difficulties of living with diabetes, you know, the daily stress. And, you know, I haven't even got onto things like pregnancy yet. You know, if you have a pregnancy with diabetes, you are going to feel guilty every time your blood sugar goes out of range. You're going to think, I'm harming my baby. Every time your blood sugar goes out of range, every time you eat something. So I think these things are quite difficult to capture. You know, the proms and prems that we have done and planning to do in a more wide scale situation, I think are quite a blunt tool for picking up some of these sort of patient stories. And I think quite often, if you listen to patient stories, I think they're more enlightening in what it's really like.
Yeah, I would agree. There's a depth to those individual patient stories that you maybe don't always get if you just have that quantitative data. And that leads me on to another question. You mentioned that you benefited from meeting the team from the financial delivery unit and the Value and Health Centre. How did that relationship occur, and what were the benefits for you and your team in terms of what you're trying to do?
Massive benefits. I think the origins were quite simple. I think it was conversations with Sally, and we discussed, you know, shall we do something with diabetes? And then we, you know, met Claire and her team in the FDU, and decided to try to look at things in a different way. And I think Claire had also been to some presentations and seen things done in this way. And we just started working on it, and there's such a massive amount of data in diabetes. There's such an enormous amount. So we just started putting it all together. And what is really fascinating, we've been working on amputations. What is really fascinating is the differences across Wales. We found the differences in spend, the differences in length of stay, the differences in outcome are huge across Wales. And so there's a real piece of work to be done in exploring why that is, you know, is the different practices. And where we've had areas of high amputation, trying to look into, say, why is this? What is happening here? You know, are these factors that we've never taken into account before? And I think a lot of what we've done when we've done our nice essential care processes of gathering all this data, and I'm not going to undermine that for a second, because I think it is really important. I think it has helped enormously to gather the data. And in Wales, when QOF was inactivated for diabetes, we've seen a huge drop off. And I think it is important, but it's all about what you do with the data. You know, you can check people's feet till you're blue in the face, but if you don't do anything with that foot check, if you don't do the next step to act on the findings, if you like, to protect the foot, then it's kind of pointless checking the feet. Similarly, you know, we do a lot of kidney checks, and I can promise you now, we will have loads and loads of people in Wales who've had the kidney checks, but the next step as to what you do with the kidney checks to prevent chronic kidney disease isn't done. So there's a lot of joined up thinking that's needed to make sure that while we collect the data, we actually do something useful with it.
Yeah.
And do you think that's tied up in, you know, this difference between quality and value? Because are both still the same? Because we've had a question here from Fern Yu, who's still just struggling with the conceptualization of quality and value. Is that something you can elaborate on?
I mean, I'm no expert on this, but I think quality is just a part of value. You know, it's just it's a component of value, whereas value is using your available resources for the best for everyone, and quality doesn't have those parameters in it. You know, quality is just about providing something that is good for an individual, good and safe, and often best care to an individual. Where we're talking about value, we're talking about providing it more to a population, but also finding out what the population thinks is good, not what perhaps I think is good, or NICE thinks is good, or anybody else thinks is good. It's finding out what the population and individual people think is a good outcome.
Yeah, and NICE do that, don't they, with their public engagement? And so what's your strategy for public engagement and finding patient priorities?
Well, we've largely done it more recently through the All Wales Patient Reference Group. We often ask questions of that group. We also are very fortunate to work quite closely with Diabetes UK, which is major diabetes charity, and JDRF, and that group has a lot of public involvement, and is able to bring a lot of valuable information to us about what people want and where people feel the services are deficient. And I think for a while, something that isn't value, we've had patient-centered care in diabetes, and we've tried to have an individualized approach to diabetes. It's much been the buzzword for the last 5 years or so, to try and make an individualized approach, which again isn't the same as value-based healthcare. But I think that's been there in diabetes. There's been attempts to understand what the individual wants, but also we've got an Audit Plus module that will include, as well as the diabetes parameters, will include things like frailty, will include things like other comorbidities, which tries to individualize for the patient what their target should be, whether they should receive deprescribing. So we have that in terms of trying to manage patient centered healthcare. But a lot of our chief drivers come from things like NICE, as well as Health Technology Wales. Although usually NICE, if NICE will decide on something, then Health Technology Wales usually just endorses it. And also we have partnership working with National NHS England as well on a lot of these factors.
But what I really like is how you've talked about patient-centered care, and that is the face-to-face sort of almost contractual care. But then you've also taken that, which is best practice, and then you've used talking with patient groups about priorities and thinking about the population. And I think I agree with you that the value fits very much with that sort of as the population view. I mean, quality can too, but certainly value brings it to that. And then linking that with the data, and then addressing the variation is obviously key to that, with steered by the priorities that you're setting. Am I summarizing that right?
I think so. That sounds much better than I could put it.
Oh, that's the way you
Julie, I was just reflecting on some of this information in your presentation, and I'm pretty sure you said that diabetes takes up about 10% of the health budget in Wales. Was that right?
That's what people always say. That's what people always say. It's a very crude figure, but that's considered to be the impact of diabetes on all those cardiovascular disease, strokes, liver disease, cancers, etc., etc.
Well, that is just a staggering amount of resource. And I'm just wondering, you mentioned about the use of data, whether that's qualitative data, prems, proms, but also your data on complications and things like that. Are there any sort of figures or statistics or complication rates that you've got your eye on that you think, actually we could shift the needle on this and really impact patient care?
All of them really, which isn't really helping answer the question, but what I really feel very passionately about is that we have to shift the resources downstream. I really want to focus on early diagnosis, because what often happens with somebody with diabetes is they'll have a bit of resource here, and then in a year a bit more, and then 2 years a bit more, and so forth, and we'll dribble in the things over, you know, the lifetime with diabetes. And I feel very passionately that we're doing people a disservice with this, and we need to get those resources in at the start. A lot of these will be things like structured education programs, and if we can put those in at the start, because diabetes is essentially a condition of self-management, so if we can get those things in as early as possible. I mentioned the hybrid closed loops. In paediatrics, the vogue now is to put patients onto those hybrid closed loops as soon as possible when they're diagnosed, and I'd like us to do that with adults as well. I think it would be far more cost effective, but also far more valuable to the individual, and it would dramatically reduce the complications if you could get this very good control very early on for people to live their lives with. So there isn't as such a particular complication, but you know, it's changing the ethos really. My whole ethos is trying to drive those resources downstream, so we are doing less complication management. And we won't obviously get rid of all complications, but I think we could dramatically reduce it. The pumps that will be out soon will be complete artificial pancreases, and this will only be for type 1 diabetes, but there'll be complete artificial pancreases, and hopefully can just be plugged in and people can be away and live their lives, albeit with a little device attached to them that acts as an artificial pancreas. And I think once we get to that stage, people's lives will be so much better. And I think for type 2 diabetes, really trying to champion that remission. You know, we've got pockets of services, tiny little pockets of services in Wales. And what I would like it to be is that everybody gets a diagnosis of type 2 diabetes is offered a remission program, so that they've got an opportunity not to have diabetes. It makes so much sense, doesn't it?
And that was going to be my next question. So is there anywhere that's just smashing this, that's tackling this problem and really delivering in Wales or elsewhere, particularly around the type 2 diabetes? Because for me, I think that, you know, there's so many modifiable factors in type 2 diabetes that I'm really interested to know, is there anybody that's smashing this? And I'm particularly thinking about, you know, the community and peer support and that sort of model, which seems to me to be a more sustainable way of getting better health outcomes for chronic conditions. But is there anywhere smashing this?
Not in remission, no. I mean, there are areas that are smashing things like peer support and this sort of thing, but remission it's fairly recent evidence that you can put type 2 diabetes into remission. You know, it's perhaps 5 years old or something like that. And last year there was more evidence that you can put people who've got a normal BMI into remission. You don't need to have you know, an elevated BMI to get people into remission. So it's really starting as pockets. Same with England, they're trying to introduce this. The way in which it's been done is quite staff intensive, and it was disrupted a lot by COVID, although we've shown during COVID it can be done very effectively remotely as well as face to face. So I think it's all about now getting people aware that this is an option for them, and then getting the services available. And I think, you know, this is an area that we should really be putting resources into. And there's been a lot of concern about deprescribing, because when people go into this sort of program, they have medications stopped, you know, blood pressure medications as well as diabetes medications. But again, my point is, if you get people early enough, then they won't have had prescribing, so they won't actually need deprescribing. You know, so I think it's very important that this is an option that's considered at diagnosis rather than waiting for people to be on 3-4 medications and then have to take them away again. It's much better to get in early and try and help people into remission.
And just thinking about your budget, and then about how you redistribute resources. So if you're prescribing less, then is that money then locked in the pharmacy budget? And then if you're doing less foot ops, does that mean that the surgeons are going to redistribute their funds? How do you sort of steward the money around your population? So if you make a saving somewhere, that you can then reinvest it somewhere else. How are you?
I think it's really difficult, and we're only just starting to have those kind of decisions. You know, whether you can move money out of for example, a medicines budget into a budget for dietetics to try and help this. But these are very early conversations, and the problem is that the money it's not there in a neat little pot. You know, it's so entrenched in the healthcare system that it's very difficult to realize savings in that way, because those savings will often be 20 years down the line. So, you know, you'll get your immediate savings of drug costs, but your biggest savings is going to be, you know, down the line, not needing your coronary artery bypass graft or your amputation or dialysis. And it's very difficult to redistribute that money, and I think it's going to take a lot of enlightened financial thinking
Yes.
by people at the very top to be able to refocus resources in that way.
And one of the dilemmas you presented, the second one again, you presented the first, is that there's many factors that contribute to someone's outcome, you know, and you cited, you know, not only the experience of having diabetes and how that affects your diet and your exercise, but also then there's family relationships in that. There is the view of people at work or at school. And so you've got those factors, and how do we then extract funds? Because these factors then affect all of those with long-term health conditions. And so that, you know, how do we then facilitate the care where there is distress or what we call mental health problems? How do we support those across the board rather than just thinking about a specific diagnosis? Is that something that you'd thought of?
It's not something that I've specifically thought about, but I know there's a lot of thinking around this. You know, chronic conditions in general, I think we'll all have similar psychological distress, and it's how we do this is very difficult. You were talking about families. You know, we know, for example, in the remission work, that when people go into diabetes remission, it also affects their whole family, because usually the food choices for the whole family change. So we've had spouses and kids that have also been overweight that have lost large amounts of weight, and it's very difficult to capture that as well. It's you know, a risk factor for diabetes is having a spouse with diabetes, because you eat the same quite often. So, you know, it's very difficult to capture that kind of data. And I think you're absolutely right. We are going to need, you know, mental health support, distress support, psychological support for long-term conditions, for lots of different long-term conditions. And it does make sense to have something that is multi-condition specific. I mean, there are certain psychological distresses that are specific to diabetes, but a lot of them are you know, part of the burden of living with a long-term condition, and I'm sure those are across the board. And you know, I think that that people are starting this, you know, the peer support, you know, the often the patient-led groups, often interventions, such as the expert patient program, and this sort of thing is aimed at supporting people with living with long-term conditions. But I think there's going to need to be a better strategy, really.
Yes. Yes.
So Julie, it's interesting for Nick and I listening to what you've been sharing with us, because those themes of redistribution, and some of this has been picked up in the chat, and about bringing, you know, identifying resource and liberating resource, and it being felt in other parts of the health system, are common to many of the conversations we've had. And I know Sally Lewis is listening on the call, and I wanted to give Sally the opportunity to come in as well, because Sally, I imagine that some of the themes Julia is grappling with are seen by teams across Wales trying to improve care.
Yeah, hi everyone. Hi Julia. I mean, I think Julia's completely nailed it really in the description today, and the types of dilemmas that we're facing in the healthcare system today, where we you know, we use quality and processes to try and reassure ourselves that we're doing a good job in tackling the problem. But of course, that doesn't help if we have big gaps in services, or are not reaching people who are particularly at risk and not engaging with our services. So as a GP, I remember, you know, people not coming for their quality and outcome framework checks, you know, not coming for their foot checks. So how do we focus in on people in a different way? But there were two reflections I had really, mainly from what Julia has said. One was around the data. So there are limitations to data, of course, and we do need to personalise care and have that narrative, but we also need the quantitative data alongside. So I think it's a triangulation of narrative and people's stories and that human aspect, but coupled with that quantitative data. And the reason I say that is leading into the second point, which is how do we change this then at a national level? How do we shift the dial? And narrative alone, unfortunately, doesn't do that, because what we need to be able to be saying to our colleagues right at the top of the healthcare service who are holding the purse strings or making the big decisions, this is the size of the problem. This will be the cost of doing nothing, the human cost, the organisational cost, the national cost. So actually, we do need to structure our finances differently. We do need to think about how we pick up the priorities that Julia's just highlighted, for example, around type 2 reversal, or using technology to really get in early with controlling diabetes and prevent those complications. So I think the work that we will now do with Julia, Claire in the finance delivery unit, and others, is to try to take that forward to get a different approach to decision making. I mean, I think we have to, don't we? Because you know, there's a huge wave of diabetes coming at us, and this problem's only going to grow. So thanks, Julia.
Thanks, Sally.
And Sally, while we've got you on the call, I'm just interested. We were learning from Julia how she went about trying to fix this problem, or this collection of problems and challenges. And I'm just wondering what the local health boards are doing, because obviously Julia is operating at both the local and the national level. And how does the national work that Julia is doing with you and the Welsh Value and Health Centre, how does that dovetail with what the local health boards are trying to do for their population?
Yeah, well, of course, all the local clinical teams are grappling with the same issues, and you know, trying to get similar things done. So we now have a network of value-based healthcare teams in the health boards, supporting the clinical teams in addressing that. So I think Dee Lowry's on the call. We've just had an excellent presentation from Dee about some of the work that she's been supporting in Cwmtaf Morgannwg Health Board, for example. And sometimes that just needs very small amounts of investment to get something going, and sometimes it doesn't need any investment at all. But the point is that clinical teams in the health boards all have a team now that they can go to for some support, and all of those teams link in with us in the centre. So we're constantly trying to learn from the bottom up, and we're constantly trying to feed that back into policy and decision making to try and change the way we do things in healthcare.
Fantastic. Well,
I've just got another question. I think we've got 2 or 3 minutes left. And it was there were 2 questions actually. The first one's a really simple one. Is, you know, I've heard a lot about the Diabetes Institute in Rotterdam, where it's largely tech-based, but it would seem to me that it would miss the complex care. What's your understanding of that, Julia?
Yeah, diabetes have got excellent results. Yeah, yes. It's largely young people with type 1 diabetes who go to Diabeta, and they have got some fantastic results. And I think that is largely the integration of tech. They've integrated tech, and they've really changed what people are doing. They've managed to devise a system where people are seen by need rather than by, yes, this is what we do. We see them 3 monthly because that's what NICE say we do. And they've really managed to, I think, engage young people very well. And, you know, their results speak for themselves in that they've got much better outcomes than most places. And I think it would be, I think getting the whole Diabeta set up to Wales may be difficult, but I think there are components of it that we could very easily have in Wales. So, for example, their tech is there for the taking almost, and it would enable, you know, a shift in the way in which we did things in Wales, which I think would be very welcome. Yeah, I think they've got a great philosophy. They've got a great ethos, and they've also got some very great tools. And I'd like to get my hands on their tools if I could.
Their ethos, isn't it? You know, which is, it's very empowering. And you talked about how this is a self-management condition, and because it's a lighter touch in many ways, you know, it then encourages people to, there's less paternalism and more empowerment. It's sort of some of the ways that I've thought about the Diabeta.
I think one of the things that we've done in the UK, because we've had standards and audits, we become a little bit obsessed by them. You know, we've got to do it like this and this and this, and we focus on the collecting of the data, that our data is, you know, there's got to be above 90%. It's got to be, you know, and we have to hit these targets, and if we don't hit these targets, and I think we do sometimes not focus on the person, and we focus a bit too much on what we've been told is, this is what quality care looks like, this is what you must do. So we try and achieve the standards rather than, you know, particularly think about the patient behind it.
Well, fantastic. Well, Julia, thank you so much for joining us today, and thank you to Sally and the team in the Value and Health Centre. Nick, any particular take-homes for you from today?
Listen, I found this brilliant, absolutely brilliant, Julia. You know, there's so much. This was such a rich conversation that it'd be difficult to pick, you know, a particular theme. And I think it just comes back to, how do we empower, and how do we distribute resources to those who most need it? We haven't produced the answers, but what we've done is we've covered some of the potential barriers or the difficulties in trying to reach everyone. So thank you for that.
Yeah, thank you. And for me, you know, one of the challenges that people keep sharing with us on the HealthCast is around the complex problems and the challenges around identifying what to improve and how to go about improving it. But one of the encouraging things is about the common threads that we keep hearing. and the resources that are available more and more to people trying to do value work in Wales, you know, the Value and Health Centre, the Financial Delivery Unit, using data to knowledge and some of these other teams and resources. So lots of encouraging things there for the future. So from Nick and I, thank you very much to everybody for joining us today and for asking all the questions you've asked. We'll endeavour to find answers to any of the questions we haven't addressed during the session today and put them on the website. That's the Wales Value and Health website. These are our monthly sessions, and now that you've signed up to this session, we're letting you know in future what the upcoming sessions are, and we hope to see you as part of those.
Yeah, there've been lots of brilliant questions today, and I've wanted them all in, but unfortunately we haven't enough time. So thank you for your questions. We really value them. They trigger loads of questions for us. So thank you.
Right. Bye, everybody.
Thank you.